Morning, everyone. So I'll be starting this session with with the talk and for the next 10 minutes or so. So my topic is indications and general considerations for glaucoma drainage surgery. So a glaucoma drainage implant, they are basically designed to divert aqueous humor from the anterior chamber to the external reservoir. There is mainly a fibrous capsule which forms around the period of 4 to 6 weeks, and it regulates the flow and controls the intraocular pressure. So mainly it's successful in controlling IOP in eyes with previously failed trabeculectomies and the eyes which have a scarred conjunctiva. So coming to the basic introduction of the tubes, it mainly consists of a tube and the plate design, and they are different in sizes and material at the end of the plate, mainly silicone or polypropylene, and a presence of the absence of the valve device is the main classification factor for these GDIs. A valve implant constitutes of a Krupin or commonly used Ahmed glaucoma implant, and a non-valve devices are mainly Molteno, Barwell, and our Indian-produced Orolab aqueous drainage implant. So an Ahmed glaucoma valve, which is a Venturi-based valve system, it prevents post-operative hypotony and its related complications because of its unidirectional valve. And the disadvantage is that it's associated with bleb encapsulations, and it also has an hypertensive phase and sometimes an inadequate intraocular pressure control. While a non-valve device, mainly Barwell implant and Adi, they require a temporary ligature suture or a stent suture, because otherwise there will be immediate post-operative hypotony since they don't have a valve. And IOP should be maintained for like intraocular pressure controlling medications should be maintained for around 4 to 6 weeks post-operatively, and these devices carry a risk of hypotony in the post-op period. General indications, most common is high intraocular pressure on maximum tolerated medical management with a history of prior failed glaucoma filtration surgery. Other indications could be aphakia and cases which have a high risk of failure, like neovascular glaucoma, uveitic glaucoma. And later on, some other indications could be status post-pars plana vitrectomy or post-penetrating keratoplasty. So basically, glaucoma drainage implants are treatment of choice for refractory glaucomas. So a good clinical examination is essential in deciding about the quadrant as well as the device size and everything. So you must choose good size and do a good clinical examination. So the conjunctiva has to be healthy. The sclera also should be healthy, and there should not be any thinning or necrosis. Like in this case, we can see that there in the superior temporal quadrant, which is the most preferred site for implantation of a GDI, there is scleral thinning, and the conjunctiva also appears unhealthy. So inferior temporal quadrant had to be chosen. So we should do a good pre-op examination to look for any problems which you may encounter in the intra-op period. A good anterior segment examination in the form of looking for any iris new vessels, any vitreous in the anterior chamber, which you may have to do a vitrectomy at the time of surgery, anterior chamber depth to avoid any touching of the iris or the cornea, a good corneoscopy examination, because if you don't rule out peripheral anterior synechiae, that may interfere with insertion of the tube, and lens status, because the placement of the tube into the AC can be decided based on the status of the lens. Either you can do a sulcus placement in a pseudophakic lens or a plas planar placement in a phakic patient, or a combined surgery, you can combine it with a cataract surgery in a patient who has significant cataract at the same time. Other considerations, like if you should look for the patient's periocular condition, whether this eye is deep set, if the eye is too short, and if there is any prominent nasal bridge which may interfere with your surgical procedure. Anesthetic considerations could also be taken care of. One is the medical comorbidities. If the patient is on any blood thinners or any other medical management, you need to rule out all that. Patient's cooperation is important along with the surgeon's comfort. So in some cases, general anesthesia may be reserved in only specific circumstances. Otherwise, we prefer peribulbar anesthesia. And also the anesthesiologist should be aware of any other systemic side effects or drug interactions that the patient is already on. Coming to the selection of the glaucoma drainage implant, for a beginner surgeon, a valve device may be preferred because you are only localizing to the single quadrant, the Also, as I already discussed earlier, a scarred conjunctiva may also determine the implant size, and also the need for a good scleral patch graft. We can also, because there are modifications where a scleral patch graft may not be needed also in some cases. So you need to decide that based on the clinical examination. Coming to the preoperative intraocular pressure, that is also a basic consideration in deciding what type of implant you want to put. If the preoperative intraocular pressure is very high and you want the pressure to be controlled immediately, so a valve device like an AGV is preferred in such cases. While in other cases where the intraocular pressure is in high teens or late 20s, it is controlled on maximum medications, and you may continue it for the next 4 to 6 weeks as well. Then you can think of a barbell or an ADI implant in such cases. But if our patient is not compliant with any oral medication or a topical medication, then you want immediate control of intraocular pressure, so you prefer a valve device in such cases. Along with that, on the vitrectomy side, there is a risk of post-operative hypotony, choroidal detachment, and then we may prefer a more predictable glaucoma implant, that is an AGV, because there is always a risk of hypotony in non-valve devices. Other special considerations are uveitic glaucoma, because again, these cases are associated with high risk of hypotony because of the underlying inflammation. So we should be cautious in implanting a non-valve device. And also in cases of pre-existing buccal or band, where a large surface area needs to be dissected, and it's difficult to implant a large implant like a ADI or a barbell, because you need to manipulate a lot and there's limited space. In such case, again, an AGV is preferable. Other cases like post-peritonitic keratoplasty or phakic cases, we have our departmental publication also which says that both ADI and AGV have fared equally well. So again, it's surgeon's decision or surgeon's factor. Other conditions like childhood glaucoma, where it has been shown in various studies that GDD is beneficial in treatment of refractory glaucoma, but you must remember that the child's eyes growing and complications like tube migration, tube exposure are commonly encountered. Apart from that, pupillary irregularities, lenticular opacifications are also seen, but we still don't know the long-term outcomes. There are limited studies with long-term outcomes of glaucoma drainage implant in children, and still a lot to learn in this. And also, it's very essential because the surgeon's experience and comfort counts a lot, and any surgeon who is more experienced with a particular type of device may choose to implant that device irrespective of the associated complications. Last but not the least, the cost of implant of the surgery is very important, as we know that ADI is available at a fraction of a cost of that of AGV. So in country like ours, we may prefer a non-valve device like ADI over AGV because the patient may not be able to afford it. So to conclude, a glaucoma drainage device, they are all successful in controlling intraocular pressure in refractory glaucoma. There are numerous modifications and techniques that have enhanced the outcomes and minimized the complications. The benefits of each implant in reducing intraocular pressure must be interpreted in the light of its surgical complications. So individual characteristics of the patient and the surgeon's comfort and experience with each of the device is critical in selection of the device. Even in the worst case scenario, a surgeon may opt for a non-valve device in our setting. Thank you.